The opinions expressed by ResusLogix or Dr. Montano do not necessarily reflect the views or positions of his employer, past or present.
All right, let's jump right in. Today, we're tackling one of the most frustrating problems in critical care, that moment when the monitor looks great, but your patient is clearly still in trouble. We're going to be talking all about a concept called hemodynamic incoherence. You know the scene? We've all been there. You're at the bedside, you've been resuscitating a patient in shock for hours. The map is finally over 65, the cardiac output is solid, the numbers look beautiful. But the patient? They're not turning the corner. Their lactate isn't clearing, their skin is mottled, they're just not getting better. So what gives? This is the central mystery we're going to unpack today. So let's start by putting a name to this. It's called the resuscitation paradox, and it's a huge deal because it points to this fundamental and, frankly, pretty dangerous disconnect in how we've traditionally thought about resuscitating patients from shock.
The formal term is hemodynamic incoherence, and the definition really says it all. It's a state where fixing the big picture numbers, the stuff we call the macrocirculation, doesn't actually fix the problem where it counts, down at the cellular level. The link, the coherence, between our systemic goals and tissue perfusion is just lost.
This slide just lays out the problem so perfectly. On the left, you've got our goals, right? We're high-fiving because we hit a map over 65. But on the right is the grim reality for the patient's cells during incoherence. They're still facing hypoperfusion, they're still not getting enough oxygen. It's like we've tuned up the engine, but the fuel line to the cells is totally clogged. So this begs the question, right? If the big numbers on the monitor are misleading us, how in the world can we see what's actually happening at the tissue level? Well, let's look at the tools we have to peek into the microcirculation, right there at the bedside. We actually have a few ways to get a window into this hidden world. Some of it's pretty high-tech, like sublingual video microscopy, where you can literally watch red blood cells moving or not moving through capillaries. Then you have things like lactate clearance, which we all use as a surrogate for perfusion. And let's not forget the simple stuff. Your physical exam, checking capillary refill, looking at skin modeling, those are actually powerful clues.
But here is the absolute kicker. This is so important. While these tools tell us a patient is doing poorly, they haven't been the magic bullet for treatment. A huge trial in 2023 found that even when clinicians used this microcirculatory data to guide their therapy, it made no difference in survival. So what does that tell us? It tells us that just seeing the problem isn't enough. We have to understand why it's happening.
And that brings us to what could be a major breakthrough. Instead of just saying that microcirculation is good or bad, there's a new framework that helps us classify why it's failing. It's a way to bring some order to the chaos and identify distinct patterns of failure. The first phenotype is S for stasis. Think of this like a traffic jam on the highway. It's all about impaired outflow. Maybe you have high venous pressure from fluid overload or a struggling right heart. It creates this back pressure that stops blood from leaving the capillaries. Flow just grinds to a halt.
Next up, L for leakage. Here, the problem is that the capillary walls themselves are damaged. They become permeable, like a leaky garden hose. So all that fluid we're giving the patient just pours right out into the tissues, causing massive edema and actually making it harder for oxygen to get to the cells.
Then we have O for occlusion. This one is often our fault. In our rush to get the blood pressure up, we can crank the vasopressors so high that they paradoxically clamp down on the arterioles and just choke off blood flow to the tissues we're trying to save.
The other O is for obstruction. This is a physical blockage from the inside. In states like sepsis, you get inflammation and coagulation, leading to tiny little clots and clumps of cells that literally plug up the capillaries. It's a roadblock right in the vessel itself.
And finally, P is for paralysis, or what we call vasoplegia. This is the exact opposite of occlusion. Here the vessels lose all their tone. They become floppy, dilated, and just stop responding to our pressors. We can be pouring in vasoconstrictors, and the vessels just don't care. They're paralyzed. And this table right here, this is the money slide. It brings the whole SLOOP framework together beautifully. This is our roadmap, adapted from the work of Huang and his colleagues. It connects each phenotype to its mechanism, the clinical signs you'll see at the bedside, and even what you'd see if you could look directly. High CVP, think stasis. Bad edema, think leakage. This is how we go from a vague problem to a specific diagnosis. Okay, so identifying a phenotype is great, but it's only useful if it actually changes what we do. So let's look at how this framework can make our treatments targeted and, most importantly, actionable.
The proposed treatment algorithm is just good, logical medicine. Step 1, you always have to stabilize the big picture first. You can't fix the micro if the macro is a mess. Step 2 is recognizing you have incoherence in the first place. Step 3 is the big one, using all your clues to figure out the dominant sloop phenotype. And only then, in step 4, do you deliver a therapy targeted to that specific problem.
And this slide shows exactly what that looks like. The logic completely changes depending on the phenotype. If the problem is stasis, you don't give more fluid. You do things to reduce venous congestion. If it's leakage, you slam the brakes on fluids. For occlusion, you might actually need to back off the pressors. You can see how each diagnosis leads down a totally different and sometimes counterintuitive path.
So, let's zoom back out. What does all of this mean for the next patient in shock that you take care of? What does it mean for the future of how we approach resuscitation and critical care?
What we're talking about here is a true paradigm shift. For decades, shock resuscitation has been driven by one-size-fits-all protocols. This SLOOP framework is all about moving away from that toward a much more precise, personalized resuscitation strategy that's tailored to what's actually going wrong with that individual patient. And that really leaves us with this final thought. By looking beyond the arterial line, by using our brains and our tools to classify the chaos in the microcirculation, are we on the verge of the next great leap forward? Now look, this framework still needs a ton of validation, but it challenges us to think differently, to think more deeply, and to treat the patient, not just the monitor.